So part of our November EMS training on scene safety is based, of course, on infectious disease and PPE, and we wanted to provide some facts. So here's kind of the baseline that we're looking at, and we've backed up to square one. This is not specific for Ebola virus disease or other of those sorts of issues and risk. This is really just looking at the whole broad spectrum. What's the deal here? Well, some of our patients have infectious diseases. In order to protect ourselves, we have to assess our risk. We don't need to wear everything all the time on all patients, but the problem is that we have a hard time assessing that risk when we immediately encounter the patient. That risk assessment can be accomplished without a necessary risk as long as you can remain outside a 6-foot action circle around the patient. If your patient is stationary, that's a lot easier than if the patient is up and moving around. And so this whole concept is based on the 6-foot action circle. If you're going to need to be in that action circle prior to completion of a risk assessment, the only safe practice, the only logical approach to this is to wear everything that you might need to protect you from infectious disease. Once you're able to do that risk assessment, then you can remove as needed to where it's an appropriate level of PPE that doesn't interfere with your comfort or your ability to take care of patients. So how do you decide on what PPE? That's based on kind of a brief synopsis here of infectious disease transmission. It occurs by 3 methods: by droplet, by contact, or an airborne sort of transmission. Now, the airborne, fortunately, is much less common, and that's the one that's a little bit harder for us to protect against. So droplet, contact, and airborne are needed for patient care inside the action circle when the patient is suspected of an infectious disease. You don't know that right off the bat. So you have to do a risk assessment, which takes time. And while you're doing that risk assessment, you've either got to stay outside that 6-foot circle, or you've got to have everything on if you're going to go inside the circle. That's the only thing that we can come up with that makes any sense. So here's what the protection is for droplet. It's goggles, not glasses, goggles and a mask. Not specifically N95, but that's the mask that we have. And so the N95 offers you a higher level than your plain surgical mask, but technically the surgical mask is what's needed for droplet. If we're dealing with contact, then we need to have gloves and not have exposed skin, therefore the sleeves, long pants. Again, which can be accomplished with bunker gear, wildland coat, a number of items of PPE that we already have in place for all the other risks that we encounter, all the other hazards in the fire and rescue world. If a substance is transmitted via airborne methods, then the N95 mask is appropriate. So just looking at the bottom of that screen, you can see that N95 mask with goggles, gloves, and sleeves and pants are the protection for droplet, contact, and airborne if you need to cover yourself from all 3 of those. So we're thinking that a process that makes sense would be for contact and cover, our 2 roles of our 2-person crew. The contact and cover people begin assessment situation at dispatch, and it continues throughout the call. This whole old outdated notion of saying BSI scene safe and thinking about it for like 5 seconds while you say that at the beginning of your interaction with a patient is just unsafe, and it's absurd. And so we've more or less outlawed that phrase, at least in our initial education courses here. So contact and cover, start your assessment as soon as you hear the call. Given on the nature, realize that 911 Center gives you as accurate information as they can, but if they get bad information in, they're not going to be able to somehow magically give you really good information from bad information they got in the first place. Part of your assessment of the situation includes the risk for infectious disease. It also includes the risk for violence, the risk for something falling and hitting you, somebody's dog biting you in the leg, and numerous causes of potential harm and things to consider in your risk assessment. Infectious disease is just one of those. But it seems like maybe we have minimized that, particularly with this BSI seen safe mentality. We've just kind of minimized that. And now Ebola has brought that to the forefront and has triggered us to reevaluate our entire approach. And it seems like it's going to be a more reasoned, thoughtful, appropriate process going forward. Now, some information you can gain during dispatch, some you can gain as you contact the patient, other people at the scene. You can get information to some extent, to some level, as you begin to approach the patient. It's sort of like a hazardous material in that the closer you get to the patient, the more accurate and the deeper and broader of the information that you can obtain, but you're putting yourself at increased risk. So there's this trade-off between closeness of contact and inaccuracy of the information. So our rationale here is that contact and cover don't need any PPE until they enter that 6-foot action circle, technically, theoretically. That's silly, but technically they don't need anything until they're within 6 foot of the patient. Again, as long as your patient's sitting still, the moving target problem is not in play. But it seems prudent that you would that you would have full PPE rapidly available, whether that means already on or you can put it on in a matter of seconds. There's some room for judgment there. Maximum caution dictates use of the full PPE outside the circle in case you have to get inside the circle. Now, contact will likely need gloves, long sleeves, and pants because no matter what you're going to do with that risk assessment, this is pretty standard cover that you're going to need. The cover person who's acting as RIT wouldn't necessarily have to have that all on, but needs to be able to rapidly put it on in order to fulfill their RIT role. Okay, so the following SOG, written as simply as we can, and so almost every word matters. Until a risk assessment proves otherwise, any person operating inside the 6-foot action circle should have full level D PPE, which means pants, long sleeves, so there's minimal, if any, exposed skin, and certainly your arms are covered, your knees are covered, so that you can get in a patient care providing position. You need an N95 mask, because if it's airborne, you need N95. You don't know if it's airborne until you can do an assessment to prove otherwise. You need goggles because you're not sure if there's a droplet splash concern. Patients can suddenly vomit. They can suddenly cough. And you're not sure what you're getting into until you can do that risk assessment. And then gloves. Now, gloves is an easy sell because almost everybody wears gloves on everything all the time these days. Wasn't always so, but it is now. And that's a good custom and a good standard practice that we don't want to change. So until a risk assessment proves otherwise, you got to have it all on. If you can get a risk assessment done before you get inside the 6-foot circle, then you can wear what's appropriate. If you're not in the action circle, then the risk assessment dictates the PPE. So we hope that this is a reasoned approach that trusts that you can make an assessment, that you can use judgment, and that you can do what's appropriate. And it's very similar to what we do for any of the other things. It's an all-hazard sort of approach. We don't necessarily wear an SCBA with full bunker gear to enter every house where there's a smoke odor. You make an assessment on what you need. We have you make a risk assessment in everything that we do, and medical calls, of course, being the majority of what we do, medical calls include this risk assessment. It's not just about infectious disease, but this is a key emphasis now in an attempt to get us to really make that risk assessment and decide what we need.